get started? Right, I'm hoping to be on time, start to finish. So most of you know me, but for those of you who don't, my name is June Lee. Started CB medicine in 2008, so it's going back many years now. We do a lot of hormonal therapy, weight loss management. We do a very good primary care. We do a lot, but mainly we do a lot of support for family. And a lot of the time when family comes in, it usually starts with a woman bringing in herself and then her husband and then her parents and then her girlfriends and then her children. So today's topic of perimenopause and menopause speaks to me loudly as many of my patients are women. And we suffer in the space of 40 to 60 to even into 70s, going through hormonal changes. And hopefully in today's talk, we can go over some of the definitions of perimenopause and menopause and figure out how we can best support you. And hopefully you learn a few things to make yourselves comfortable. All right, let us begin. All right, so objective of this talk is first to understand where you are in your menopausal map, and I'll go through the map with you. What is exactly perimenopause and what is menopause? When does it start? When does it end? Does it ever end? And what are some of the symptoms that are associated with it? Then we'll go through the benefits of hormone replacement therapy, debunk some of the myths, including blood clots, stroke, breast cancer risks. And we're going to talk about how safe bioidentical hormone is, how it can benefit all of us. We'll go through lifestyle, we'll go through supplements and nutrition before we go through the hormone replacement therapy. And if anybody want to sort of shout in, participate, do a little bit more of a discussion-based learning as opposed to me going through the slides, that would be awesome. I know everybody's muted, so I don't know how people are going to just chip in, but you can raise your hand. And I think Amber is my co-host. So if anybody raises their hands and want to ask a question, feel free to interrupt during the talk. All right. All right. So we created something called a menopause map. Want you guys to kind of go through this map and sort of figure out, where am I? Like, am I in this late reproductive phase where my periods are coming a little bit more frequently? It's a shorter cycle, but it's still coming kind of regularly. There's some change in flow. Maybe I'm experiencing a little bit of a worsening of PMS, a little bit more crying spells, a little bit more irritable, maybe having a little bit of trouble sleeping, memory loss, brain fog, but still having almost regular period. Yeah, that's late reproductive phase. You can still get pregnant here. And then there's the early perimenopause state where the irregular periods are a little bit more profound, and the cycle length can vary between like 7 days, 7 to 10 days, even maybe 14 days. And other annoying symptoms starts, sort of more than just mood changes, maybe a little bit more depressed, maybe really getting to be insomnic. And length of time that a woman stays in this phase is a little bit more variable. And then we go through late perimenopause. This becomes a little bit more profound because the periods become really more scanty. You go through 2 or more months between your period. Maybe you have like a period every quarterly, but it's not so regular. Maybe you have 1 or 2 days of spotting and then no period for 3 months, and then you have a period. Some women stay in this phase up to 3 years. Some women go through it within a year, and then you get that boom, final period. And then if you don't have any period for 12 months, then you're in menopause. So menopause is really a one-day thing. You can't really know what that one day is until you've gone through 12 months, but menopause starts in a day. You don't have your period for 12 months, then you're in menopause. That period is called early menopause. Some people go through it within five years. Some people go through it even up to 8 years after your last period. And this is when women suffer the most. Have flashes, night sweats, vaginal dryness, painful intercourse comes during this period of late perimenopause to early menopausal. And then you go into late menopause for the rest of your life. This is when you really start seeing ovarian failures, meaning there's no more estrogens coming out. Estrogen keeps dropping, dropping, dropping. And then you go through accelerated aging. So there's no more mood fluctuations because all the hormones have stabilized. But symptoms related to low estrogen, especially like vaginal dryness, frequent UTI, uterine prolapse, wrinkles on your face, graying of the hair, all of that starts becoming a little bit more accelerated. That's the map.
So I definitely am experiencing the irregular period. What was interesting is my cycle had stopped for about 9-10 months, and then all of a sudden it started again. And I'm like, oh no, now I got to start the count of 12 months all over. And then definitely the sleep disturbances, because at first, before entering into this phase this past year, I had insomnia. And so now that I'm in this phase, I'm like, wait, some of these symptoms could have been connected to perimenopause, but everything was kind of like isolated, like the mood changes, the fatigue. And I didn't realize that was what I was experiencing.
Right. Perimenopause can be quite a distressing, but you hit on a lot of stuff. Irregular period, no period for 9 months, mood disturbances, sleep disturbances. Some people get more frequent migraines. Some people really feel like, oh, my breasts are really tender and my nipples are sore. This is when you're like, husbands don't touch me because I'm just like irritable and everything sucks. Some people experience dry mouth, like change in their body odor. Some people feel pain in their vagina, and they also feel like their breasts are getting a little bit. That's perimenopausal symptoms. Once you have no period, but some people have hot flashes and night sweats before no period comes. They start having that temperature regulation problem. What are some of the menopausal symptoms that I have experienced or is experiencing? Anybody willing to share what you're going through?
Hi.
Hello.
I'm past perimenopause, but I had a lot of these symptoms, and I was wondering, because I read about other symptoms that are not usually, or that traditionally doctors have not associated with perimenopause, but could be like vertigo, like um these strange feelings in hands,
Mhm.
tingling and numbness. Is that something you would also consider a symptom of perimenopause?
Yeah, no, 100%. So other than the obvious, like hot flashes, like night sweats, thanks for sharing that. Some people actually feel dizzy and they go through like palpitations or they get vertigo, or some people even get tinnitus. They're like, oh, I suddenly have like ringing in my ears. And the dizziness, the tinnitus, the vertigo, because it's such a neurological or inner ear problem, people don't attribute it to hormonal dysfunction primarily. They go and see an ENT doctor, they go and see a neurologist. And then once everything is ruled out, then finally people look at like hormonal dysfunction and say, oh, maybe it was a hormonal roller coaster or disturbances in hormone that's causing that dizziness and vertigo and tinnitus and all of that. Our GI tract also, there's more heartburn happens, harder to digest food, you get more bloated, down to like, oh, I never had allergies in my life, and suddenly I'm allergic to so many different things. What's going on? And people have a harder time gaining muscle. They feel weaker. They have a much easier time gaining fat. Fun stuff, right? That's what happens with menopause. But is there any benefits? Yeah, no, I'm 49. I'm turning 50 this year, and I'm certainly like looking forward to no more periods. No more carrying around tampons and no more period stains on my bed sheets. All of that I definitely am looking forward to it. And because there's less of a hormonal roller coaster, people become more stable once it's all said and done, once the menopausal phase is sort of like settled in. less headache, less migraine headaches, can have sex and enjoy without being worried about getting pregnant. Women with fibroid, their fibroid definitely shrink. Or two, these women with fibroid also have suffered from heavy menstrual periods and anemia all their lives, right? All their reproductive lives. Kind of nice. And this menopausal period usually coincides with our children going to college, becoming empty nesters. So you really do start having more time for yourself. You kind of have figured out who you are. You don't really care what other people think of you. So there's more self-confidence and inner strength that comes. So we kind of know when we're going through perimenopause or menopause things, because we kind of feel the difference, whether it's weird symptoms or obvious symptoms. We're like, oh, like I really feel differently now. Something must be changing in my body, whatever that is, right? But if another woman walked by, if I walked by you, or you looked at somebody, can you actually tell if somebody is in menopause or not? A lot of it is happening inside, right? But some of it, as menopause really settles in, does happen in our exterior. Our skin starts wrinkling, we start drooping, our hair starts graying and thinning and falling out. Our postures, our bone becomes brittle, so we're stooped more forward. We lose muscle and our fat distribution changes, and even joint pain and joint deformity starts happening. The structural degenerative changes, external looks, accelerate after menopause. This is all different speeds of aging, right? Some people have early menopause at age 36, and some of us have very late menopause at 56, and we certainly have heard of a woman who had her last child when she was 50. I had my last child when I was 40, and it was like, whoa, 40 and I'm pregnant? What's going on? So our reproductive age definitely varies, and we definitely go through different speeds of aging. But these degenerative changes of structural stuff, what's most common complaint that I hear as a doctor is, whoa, doc, I suddenly gained weight. What's going on? My hormones are gone and I'm gaining a lot of weight. Rapid weight gain is one of them. Now, this woman in the middle, the young woman, maybe 120 pounds. This older woman may also be 120 pounds, but this older woman is what I call skinny fat, which means her fat distribution has changed and her bones have become brittle and her muscle have weakened and atrophied. So no matter what the weight is, there's more fat than muscle. And those of you who come to our practice know that we do InBody all the time. And when InBody starts looking like, oh, you have more body fat mass than skeletal muscle mass, you have an increased visceral fat, and then percentage body fat goes up. It doesn't really matter how much you weigh, you have what we call sarcopenia. So why do we go through these changes, and what do we see? What do we not see that's happening inside? Our GI tract changes, less digestive enzyme is being produced. Therefore, you go through more bloating, more bowel movement changes and whatnot. Our brain neurotransmitter changes. Therefore, we have sleep disturbances and more depressed mood and anxiety. Our immune cell changes. There's something called immune aging. Therefore, suddenly we have allergies that we never had, and we're more prone for urinary tract infections and other infections. But at the bottom of it all, what's most important is our sex hormones. So what are hormones? We want to first define hormones so that we kind of know what we're talking about. Hormones are messengers that signal cell growth and cell death. So because of our sex hormones, when it's growing, we go through our secondary sexual characteristics of developing our breast, our butt, our curvature. And then when it goes through cell death, we kind of lose all those secondary sexual characteristics until we're sitting in a nursing home bench, and from the back, a grandpa and a grandma really, they don't look any different. There's no sexual characteristics left when we don't have our sex hormones in. So having said that, you definitely want to understand your sex hormones and the different personalities and different function that comes with your sex hormone. So I've nicknamed our sex hormones so that it's very easy to conceptualize what they do. So testosterone is generally a male hormone, but females have testosterone as well. I call that the hunter hormone, so that, in order for you to hunt in the jungle, you really have to have good cognitive function as well as physical functions. So speed, muscle, strength, exercise performance all comes from testosterone, but so does cognitive, executive function, decisiveness, sense of direction, memory, all of that comes from testosterone. What it takes to be a good hunter comes from testosterone. What it takes to be a good mother comes from progesterone. Progesterone makes us mellower. Progesterone makes us more nurturing. Progesterone is a major uterine sort of like protective measures that during pregnancy you must have it to sort of like buffer the baby and whatnot. Progesterone is what it takes to get pregnant, then carry the pregnancy through, but it is also it's a very much a nurturing hormone that lets us sleep, that lets us be less anxious and less worried as we raise our children. Estrogen is what I call a diva hormone. It's what makes us feminine and female. It grows our secondary sexual characteristics when we're growing up as a teenager. It defines our sort of body habitus, waistline, hip line, boobs, hair, skin, everything it takes to be female comes from estrogen. Hope that was a good succinct description of what those hormones are and what they do for us. And for those of us who are actually suffering from all those menopausal and perimenopausal symptoms, we're all in here because we want to know, how can I feel better? All right, I'll go through lifestyle medicine in a very see beyond way. We talk about all the lifestyle medicine in a see beyond 5 sort of pie, so I'll go through that. Within there's going to be some integrative medicine practices that's weaved in, but mostly we're going to talk a lot about hormone and bioidentical hormone. Is it safe? What are some of the myths and what are some of the facts and all that, right? Here we go. All right. 5 simple ways to sort of beat menopause would be to do sustenance well, sweating well, stress well, and sleep well, and have a good social support. And at the middle of it all is really hormonal support. I'll go through it one by one. Do solutions this way. All right, when I say sustenance, I mean a couple of things. I mean food, I mean hydration, I mean sunlight, I mean whatever it takes to really sustain our life to its fullest potential, right? So for menopausal period, when we want to lose weight, we definitely are somebody who goes like keto, 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 protein, protein, protein. But when you're really trying to get a hold of your menopausal symptoms, you definitely want to be eating more legumes, because legumes have phytoestrogen. So you want to be boosting your estrogen a little bit. And that comes from soy, chickpea, beans, peas, red clover, flax seeds, and you want to get omega-3 rich food, including fish. You want to get ample greens and with high fiber, so at least 8 servings of fruits and vegetables in there. No sugar, no processed food, as sugar and processed food definitely makes hot flashes worse. So does greasy and spicy food, and I'm sure you know this, but so does hot food. If the food temperature is really hot, it's going to trigger a hot. We definitely recommend that you cook simple whole foods at home, like almost 80% of the time. And if you have to eat out and you eat out 20% of the time, definitely skip the appetizers and desserts, as they are more inclined to be full of sugar, and order one entree and do portion. In terms of what to drink, guys know this because I say it all the time: water, 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 water only, nothing else, water, 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 8 to 12 glasses a day. So try avoiding coffee, anything caffeinated, and definitely red wine and alcohol has no place in my menopause, because everything works. Fog, dizziness, allergies, weight gain, everything. Sage iced tea is something I found in my sort of like research, and I've tried it, and it's as a cold iced tea, it's really good to sort of like regulate your body temperature down. So something, and some of the supplements that I like to prescribe a lot during perimenopausal period before you menopause fully is by Texas cheeseberry. It does bind to your brain's dopamine receptor and opioid receptors, so it does make you feel better, but it also regulates your sex hormone in a balanced way. So the deficiencies and the dominance of estrogen, progesterone just kind of get balanced out. It's miraculous how this works. So it augments where it is deficient, and it sort of removes if it's dominant and overwhelming. So it's a good balancing herb. Soy isoflavonoids are definitely something you could take for estrogen support. Evening prime rose oil is Randy's favorite, I think. She uses that a lot. Black cohosh definitely stabilizes mood, so it's better for like depressive symptoms and like anxiety symptoms. And magnesium, honestly, is our best friend. It helps sleep, it helps to be relaxed, it helps you to go to the bathroom. Definitely evidence-based supplement, anecdotally and scientifically. There's something you can add on regimen. In terms of sweat, I'm sure you guys have heard me say this all the time. We want to detoxify every day. I tell my patients to pee, poop, and sweat every day. Nobody has a problem peeing every day, but some of us definitely have problems with constipation, and some of us don't sweat every day. I mean, like driving the car and our easy modern lifestyle, we're no longer sweating every day like back in the days of farmers and hunting days. Okay? So regular bowel movement is super important. Having a very short bathroom routines, not to sit in the toilet for a very long time. This is a very much an Eastern medicine concept and Chinese medicine concept, but fighting fire with fire. So like doing hot yoga, infrared saunas, and just sort of like sweating it all out cools down your body temperature. I've recently gotten into hot yoga and I'm completely addicted to it because I love the way it makes me feel afterwards. It doesn't matter how hot it is out there. It's been quite hot this summer. I go in there and I come out like feeling like, oh my God, it's so cold and cool and breezy. So by contrast, I think it cools down your temperature. Everybody knows the benefit of exercise, better sleep, better mood, more muscle, less bone loss, good osteoporosis prevention, less visceral fat, fewer cardiovascular events, better brain function for sure. We recommend 5 days a week, 30 minutes minimum. It's better to do almost every day in a smaller duration than to do 2 hours, 3 hours one day and not do anything for the rest. Consistency and routine and practice is best. So in terms of stress, stress definitely makes hot flashes worse, right? If you're stressed out, if you're performing, suddenly you'll get like a wave of hot flash, whatnot. Being prepared, wearing layers so that you can take them off when that happens, choosing organic, breathable, natural fiber clothing, keeping a fan near you, lowering sleeping temperature in the room, temperature regulated mattresses are very helpful. Scheduling a massage or acupuncture at a regular interval is definitely helpful to de-stress. Some of my favorite aromatherapy essential oils are sage, again, like sage iced tea. Peppermint is very cooling. Citrus oil boosts libido. Lavender oil is really good if you do like any kind of warm compresses in the pelvic area for vaginal dryness and muscle relaxation for intercourse. A lot of us love like CBD pain cream. My staff uses it for migraine headache and temporal tension headache. Stress, definitely you want to manage. Sleep is something a lot of my patients struggle with. So the magic supplement to sleep is magnesium. That's our favorite. And then we formulated a sleep supplement that a lot of you guys are already on that has GABA, L-theanine, 5-HTP, melatonin, lemon balm, all the inhibitory neurotransmitters that enhances your sleep. Full spectrum hemp oil certainly helps you to downshift and relax so that you can get into sleep well. But the magic hormone here is progesterone. Progesterone definitely has a sedative effect through binding to GABA receptors, and it increases REM sleep. That means not only are you downshifting into physical repair period, you're getting a lot more psychological repair and de-stressing by increasing the REM sleep. also has a little, not as suffering with hot flashes. Social, if you're a woman, we're all very good at this. Actually, we're far better at this than men. Most of us have a trusted girlfriend group as therapy. That's awesome. Social activities like mahjong, book club is helpful. Social sports like tennis, pickleball, golf is wonderful. Volunteering at a school, church, club, and spending time with people you love and you love to serve is definitely. I think social part of menopause is that it coincides with, like I said, like kids leaving for college, some of us divorce or separation, or some of us health deterioration and death of our parents. So it could be a sad period or isolating period. I think it's more important if you're going through a little bit of a hardship to lean on your social support. Pick up the phone and call your friends and get together is what I would say. And as you're distracted, you will feel less of that disturbing, annoying menopausal. All right, so those are all the lifestyle interventions and some integrative approaches. We do hormone replacement therapy a little bit differently, so we're going to talk about that too. But if you really want to just stay young forever and not go through any of the symptoms, ultimately, we need hormones. What are some of the known benefits of hormones? Here's when I'm going to give it back to you guys and have you guys talk about what do you guys know about hormones? Who has tried it? Who liked it? How did it help? Anybody can share their experience, that would be awesome.
I haven't tried HRT, but I have tried vaginal estradiol, and I like that. It does really help with the dryness and tightness.
Great, wonderful. Like we love vaginal estradiol, which is E2. It really helps locally and that. Anybody else?
I haven't tried it myself, but I also heard that that also helps with UTIs, right? Am I...
Yeah, definitely. Because as our area, the pelvic area or the mucosal layer gets thinned out, we get a lot more frequent UTIs. Yeah, definitely decreases infection. When we're going through perimenopausal period, usually the first hormone that I end up prescribing is progesterone, because progesterone drops first. Like I said, progesterone is what is needed to become a mother. So like as the reproductive stage of our life ends, progesterone drops first. When progesterone drops first, one of the most frequent symptoms that I get as a complaint from my patients is like, I can't sleep anymore. I don't fall asleep and I don't stay asleep. So progesterone is very frequently prescribed in our practice. And it comes in like different forms, and we'll go through that too. But these are very obvious known benefits of hormone replacement therapy for our bones, for our muscles, for our skin, for our mental health, to sleep better, for vaginal, for sexual health, all of that. Some of the lesser known benefits of hormone replacement therapy is it does prevent dementia and Parkinsonism. It preserves our eyesight, glaucoma, aging of the optic nerves. Metabolically, it reduces insulin resistance and obesity. It reduces joint pain and rheumatoid arthritis and swelling. It prevents tooth loss, and it prevents kidney cancer and breast cancer. Some of you might be like, what? It prevents breast cancer? Because some people are afraid to use hormones because of breast cancer. All right, so we're going to talk about all that. All right, for joint pain, the way it works is that estrogen receptors are not just in our sex organs. Estrogen receptors are also in our cartilage, bones, synovium, and muscles and tendons. So if you replenish with estrogen, there's a significant improvement in joint pains and swelling. And then some of the myth about HRT. So why isn't everybody on hormones? Like why is only one person in this discussion said, oh, I have only tried vaginal estrogen. So what happened to systemic estrogen, progesterone, testosterone that she could have tried? Why aren't people taking hormone replacement therapy? there's a lot of fear around it. I would rather not use hormones. I have a family history of breast cancer. I had a sister, I had a friend. I hear that a lot. Have you guys felt this way, or did anybody share?
Well, what I can say about myself is I did hear about that study and about the risks. And now I heard that actually that was not done right. And there are different findings. And now I'm evaluating this again.
All right, we can all go home now. Let's go. Yeah, no, that study is called Women Health Initiative, and we're going to go into all that. Thank you for saying that. Yeah. Not everybody's on hormones, and not every doctor is prescribing hormones because of that study. Here we go. All right, so that study was done on Premarin. Premarin stands for pregnant mare's urine. When the book by Dr. Robert Wilson came out, Feminine Forever, the hormones gained so much popularity that from 1942 to 1992, there's 50 years of everyone taking hormone. But unfortunately, that hormone was horse's hormone, not human bioidentical hormone. In 1997, Premarin hit 1 billion in sale back then. Imagine how big of a number that is now. But unfortunately, sales of Premarin and breast cancer epidemic increases together and then continue to increase after that with recent decline. This is the caveat. What's the recent decline all about? So these are all different ethnic groups, but ultimately this is the population together. It continues to increase after like 1999. Keeps going, and then suddenly it's decreasing by a lot. What is going on here? That Women's Health Initiative that started in 1991 was funded by NIH, emphasized a lot of risk, put fear into every woman's heart about using hormone replacement therapy. It cited increased risk of clots, DVT, and stroke. It cited endometrial cancer risk that goes up not double, 12 times higher in women using unopposed estrogen therapy when used over 1 year. This is still true though, by the way. Then the risk persists up to 15 years after discontinuation because unopposed estrogen in a woman who has a uterus is a no-no. Estrogen single therapy is a no-no if you have a uterus. It has to be combined with progesterone to protect the endometrial lining. Breast cancer risk did not go up in estrogen-only use, but did go up when estrogen plus progestin was used. Premarin, going back to what it was before, is actually estrogen and synthetic progestin together. So when it's used together, risk increased during duration of that use, and it returned to baseline 5 years after stopping. Dementia risk was slightly increased, gallbladder disease risk was 2 to 4 times. But there was an inherent flaw in this study. It really just emphasized the risk without any benefits. And the cohort of people who they recruited from 50 to 79 years old, most of them started taking hormone replacement therapy after they were 60 years. That was a major problem. It was a major flaw in the study because hormone replacement therapy was started far later than it should have. And just by age itself, clot risk, stroke risk, and breast cancer risk were going up anyhow. So that was one of the problems of the study. So let's break it down one by one. Clots. If you take oral estrogen alone, that's conjugated equine estrogen, that's horse's estrogen, it does increase the risk of clot. But estradiol is less thrombogenic than the horse's estrogen. Estradiol is same as the human's estrogen. And when you actually change the oral to transdermal estradiol, it does not increase any clot. Now, what about progesterone? The oral synthetic progesterone, especially medroxyprogesterone acetate, does increase the risk of clot. but micronized progesterone is less risk. Stroke, I just want to make sure that you guys are all following this because it's a little complicated even for, scientists and doctors. Stroke risk is definitely low in women who are younger than 60 years old. But oral estradiol, again, conjugated equine estrogen, likely to be associated with a small increase of risk of stroke. However, transdermal topical estradiol is unlikely. So consider using transdermal estradiol with micronized progesterone for women with increased stroke risk or people who are over 60 years old is really the conclusion of the very recent study that was done in 2020, the British Menopause Society and Women. So they actually recommended hormone replacement therapy for people with increased risk of stroke, but transdermal. What about breast cancer? So that recent study that mentioned was, again, it's a continuation of study that started in 1991, Women's Health Initiative follow-up study, assessed risk of breast cancer with hormone replacement therapy, and they reanalyzed many other studies that has come out afterwards, as well as continued on their own studies, the clinical trials, and concluded in 2020 that estrogen alone actually slightly decreased risk. It was such a bad timing, 2020, because we were hit with COVID. Nobody paid attention to estrogen. No one cared. Everybody cared about COVID. So it got buried. So the news didn't really spread that well, right? So estrogen alone slightly decreases the risk of breast cancer. But if you're using Premarin, conjugated equine estrogen with medroxyprogesterone acetate, it still does increase risk of breast cancer. So that is a no-no. You do not use that orally. But even in Premarin oral use, there's no increased mortality from breast cancer. So there may be increased mortality from little risk of stroke, little risk of clot, but not from breast cancer. So it may have increased the breast cancer recurrence or whatnot, but it would not increase. So that's kind of like surprising, no? That estrogen alone actually decreases breast cancer risk. Who finds that surprising, or who knew this already?
No, that's pretty surprising to me, actually.
Right, it's crazy, right? So prior use of estrogen alone is the first pharmacologic intervention demonstrated to be associated with statistically significant reduction in death from breast cancer. 2020. I know another hormone that decreases breast cancer risk, that's testosterone. Testosterone, like in transgender transition, if a woman transitions into men and is using testosterone, obviously it's going to shrink the breast and obviously it's going to decrease breast cancer. Correct? That's common sense. That doesn't even need science, right? And then breast cancer is really more about progesterone. Like it's the type of progesterone that really matters. So estrogen and micronized progesterone has less breast cancer risk compared to estrogen and synthetic progestin, especially medroxyprogesterone acid. That was 2000. But some people knew it in 2008. We're in 2024. Where have we been? Right? What about if you really had breast cancer? What about, I had breast cancer, can I still take hormone replacement therapy? So in 2022, Bluming looked at 25 different studies and none reported increased breast mortality after breast cancer. Hormone replacement therapy after breast cancer is a yes, you could do it, but no one does it and no doctors want to touch you. Crazy, right? So vaginal estrogen we talked about. Fortunately, thanks for sharing your experience, but vaginal estrogen is safe in all breast cancer survivors. But we're still very squeamish about prescribing it. We're very fearful about using it. 2022, Journal of National Danish Observational Course. Is vaginal estrogen in breast cancer survival patients and help them enjoy sex, help them not get UTIs. Really good news. All right, so 2024 HRT decreases. That's completely up, right? The mortality rate for breast cancer is lower with menopausal hormone therapy than without menopausal hormone therapy. This is a study that came out of and national insurance database on South Korea. So South Korea, I'm South Korean, is a national healthcare insurance. So database pooling is simple and easy and big. Like, totally. For those of you who still don't believe it and really want to mitigate the risk and say, how can I make sure 100% that I'm not at a risk before I start hormone because I'm still fearful and it's an unreasonable fear, but I'm still fearful, then you test and don't guess. So Myriad Cancer Genetic Study lets you know not only BRCA1, BRCA2, but it has a TASER QSAC AI sort of software engineered risk assessment on breast cancer risk. And it goes through 5-year risk to lifetime risk. So you can assess your risk using an AI engineered software. You can useify your DNA to see what your estrogen impact on bone turnover is, as well as like cancer overall, sort of like cancer risk. You can use a Dutch test to figure out how does my estrogen, progesterone, testosterone metabolize. And I can go into it a little bit detail, but it might get a little bit too like scientific and medical jargony. But based on the metabolism of oral dosing of estrogen and progesterone, some cascades go through carcinogenic quinine, like quinolone production and 4-hydroxy-E1 production, and some don't. So if you're somebody who uses a more cytoprotective pathway, then you really don't have to worry about even taking oral estrogen. So it can all be assessed before you take anything. That 100%. So like making sure that you're not at a risk. Not just the studies, but you yourself, like your individual personalized medicine. So now I'm pretty convinced that everybody who's suffering want to start, right? So when do I start is the big question. I showed you guys the menopausal map in the very, very beginning. And I'm going to go back to that because where should we start? When do we want to start? It really depends on like how bad your symptoms are and how much of like risk mitigation you want to do versus symptom mitigation you want to do. I think I'm here, late reproductive phase myself. My periods are coming much more like shorter, like more frequently every 3 weeks. There's some changes in the flow, and I haven't really started anything. But while I was preparing for this talk, I was like, I should start something. I should at least start some progesterone or something, was my thought. At any rate, I'm going to go back to where we were before. And all right. So you really want to start within 10 years around or after menopause. I'm missing around, but definitely before 60 years old, because the benefit that you get when you start before 60 years old is far greater than if you start after 60. Major benefits are less atherosclerosis, less heart attacks, less strokes, less breast cancer, less overall all-cause mortality. And I'll go through the numbers with you again. But what about 10 years after menopause? What about 60 years old? So if you started at 62, 63, there's really no change in mortality or cardiovascular events compared to people who didn't do hormone replacement therapy. But it's never too late to attenuate symptoms and start looking younger again. I've certainly started people who are over 60, 62, 63, and they definitely report back feeling better, feeling more energetic, more self-confidence, less vaginal dryness, all of that. Never too late. So when do we stop is another question. Like if you started at 48, do we stop at 68? When do we stop? Or when you started at 52, do we stop at 56? It really is individualized and spread, personalized. It's really your choice. But use of estrogen alone beyond 65 years old increases the risk of overall mortality by 19%, breast cancer risk by 16%, lung cancer risk by 13%, colorectal. Breast cancer is actually really prevalent in women between 65. It can happen very early if there's a lot of genetic component to it, but it usually happens later in life. Cardiovascular risk-wise, venous thromboembolism, 3% reduction, fibrillation 4%, or heart attack 11%, congestive heart failure 5%, and dementia reduction. So for those of you who's checked genetics with me and have ApoE4 gene, hormone is something you should consider. But this study, if you look at this 2024 study, it actually went by types, routes, and doses. So like delivery system actually also matters. So I'll go through the delivery system on a different slide, but I'm going to go through this because we just kind of debunked all the myths, and I want you guys to transition from myth. The Women's Health Initiative created a bias towards looking for risks instead of looking at benefits. So the storytelling was all around risks, and most studies were done with conjugated equine estrogen and medroxyprogesterone acetate, which is horses hormone, which are known to increase risk of clot and breast cancer. And women participant average age was 63 years old. So because it was started too late, the benefits were really buried and the risks was ample. Unreasonable fear based on myth. And because of that study that came out in 1991, a whole generation of women missed out on hormone replacement therapy. And if I go back to one of the reasons why, that's not the only reason. I mean, mammography and sonogram and breast MRI, much better, technology got better and whatnot, but the decline of breast cancer is at the news of using hormone and bioidentical hormone, and the popularity came back, and women started using hormone replacement around this time. But this whole 1,000 to 2,000, about a decade, we're not using hormone. Now that we know, and what does it mean to be bioidentical? So estradiol E2 and E3, if you see it in this form, that's identical to human. If you see conjugated equine estrogen, that's identical to horse's estrogen. So you want to use E2, E3 in its bioidentical form. The micronized progesterone is less risk than synthetic progestin, and synthetic progestin is less risk than midrox. And in terms of delivery methods, I usually try to avoid oral hormones because of that hepatic metabolism pathways. If you are somebody who uses more 4-hydroxy and 16-hydroxy detoxification pathways, there are DNA damaging metabolites that come off of that. But if you use transdermal, topical creams, or sublingual troches or pellets, then you're really not going through the liver metabolism as much. Oral hormone. So bioidentical hormone options, as mild as supplement grade progesterone topical oil, that's only 20 milligrams. These are oral troches, progesterone troches that we have in our practice. Starts at 100 milligrams, goes up to 200 milligrams. Troches can be formulated with estrogen, progesterone, testosterone all together, or single agent as progesterone. There are certainly pharmaceutical bioidentical hormone options. I like the estradiol patch by Bel-Dot. I use that a lot. I can up and it works pretty well, other than like skin irritations and contact dermatitis. I do not use estrogen and progesterone patch ever because the progesterone is always a synthetic progesterone, not a bioidentical progesterone. I sometimes do prescribe oral progesterone 100 and 200 milligrams at night because that's still bioidentical and I feel like the risk of just taking oral progesterone is okay if you're really suffering with a lot of anxiety and sleep. So I use that quite a bit. And then we do testosterone injection, progesterone injections, and those are in bioidentical forms. And we do pellet therapy, not progesterone. It's a typo. No progesterone, just estrogen and testosterone as pellet. And progesterone, we either give it to you in a transdermal form or troche form. Or most of what I shared with you in this talk is in my book called CB on Obesity, Sugar, Stress, and Sex, in the sex hormone portion of the chapters. If you guys have any questions, now is the time, and we can talk about any slide, anything, share your experience. And I'll open it up to the floor.
I have a question. Are you finding that like most doctors are still prescribing the equine estrogen, or are they moving towards the biological?
Some GYNs are still prescribing them. You actually really have to know yourself what is biological and not rely on the doctor. Some don't know, even though they're physicians, because it requires like further training and further reading and like just self-learning after residency for you to have caught up.
That's good to know.
Yeah, no, doctors don't know it all. You really do have to talk to either doctors who actually have done the study for themselves and really figured it out, or just no, you should just you should take from this slide and just be like, okay, like no, nothing that is conjugated equine estrogen, nothing that says medroxyprogesterone acetate, and actually go through the label. Anybody else?
I have a question. I'm not sure how to formulate this, but so with all these different products, is there like one version that one gets, or does one have to sort through different kind of patches? And is this FDA approved, or how does that work?
Do you want FDA approved?
I don't know.
Okay, so compounding pharmacies' bioidentical hormones are not FDA approved, and they get criticized because they're not FDA approved. And sometimes there's a dose variation because it's a small compounding pharmacy. So pharmaceutical bioidentical options are much more reliable, honestly. That's been my clinical experience. So when I want like really reliability, I do estradiol patch by Val with oral progesterone. But if I have a compounding pharmacy that I trust and they've been very reliable on their dosing and I get good feedbacks from the patient, the easiest option is transdermal estrogen, progesterone, testosterone cream. Because it's one delivery method, simple. You put on the cream, you shower, you put on the cream. 2 hours, don't touch your partner. Shower, you put on the cream. 2 hours, don't touch anyone. So that's the simplest option because it's all together. But it's important to know your own level and figure out, do you really need all three? Do you really need all three? Or do you just need estrogen, progesterone? Or do you just need progesterone, testosterone, and not estrogen? I know that I'm an estrogen dominant woman, so I have excess estrogen. So if I were to start, I would probably start with my progesterone oil, which is like smallest dose possible, and then possibly go to progesterone troche. And then if I feel like I really want more muscle and bone and like stamina, then I would probably go to progesterone testosterone cream before I start estrogen. I probably won't start estrogen unless I'm like suffering from hot. But that's me. But everybody's different. Some people need estrogen more than anything else to get the hair back, to get the vaginal dryness back, the vaginal moisturizing back. Like, there's million different symptoms and levels that you have to put together to synthesize. So it certainly is a hard job for a lay person to figure out. And it certainly is better if you go to a practitioner who really knows this inside out and open-minded about like compounding pharmacies and whatnot, and do further testing to really see your metabolites and give you a personalized experience. Some women just need testosterone in their perimenopause period. When they're in that early sort of like stage, they just want stamina, libido, athleticism, performance, and they just need testosterone. That's all they need. Osteoporosis prevention, like their Defy Your DNA testing showed, oh, you have a genetics for future osteoporosis. You're very small boned and you know you have like very small bone structure. Then you start with testosterone. So it's not like one size fit all. And the problem with Premarin was that it was posed as this miracle youth drug that one size fits all, and everyone was taking it without any individualization. We are at time. It's 7:01. We started on time and we're going to end on time. This was by far the biggest turnout. Thanks for sharing your time with us and your experience with us. And I hope I was truly helpful to you. And if help, we're here for you. And we'll go from there.
Thank you.
Thanks for joining us.